In this video, let us now move on with learning about some of the clinical syndromes associated with the midbrain. Let us begin with the Rebirth Syndrome. It's also known as alternating oculomotor palsy or medial midbrain lesion. So this is one more cross paralysis at the level of midbrain where third cranial nerve and the corticospinal tract fibers will be involved. So patient presents with ipsilateral third cranial nerve palsy and contralateral hemiparesis. The features of ipsilateral third cranial nerve palsy include the eyeball taking a position of down and out position, that is, eyeball is abducted and depressed. Plus the pupil will be dilated because of the involvement of parasympathetic fibers. And because of the involvement of corticospinal tract fibers, the patient will be having contralateral hemiplegia. The corticonuclear fibers may also be involved, traveling along with the corticospinal tract within the crus. So the patient may show features of paralysis of lower half of the facial muscles, dysphonia and dysarthria because of the involvement of nucleus ambiguus, and paralysis of the half of the tongue muscles of the opposite side. So here the tongue deviates to the opposite side to the lesion. The only way you can make out whether it is an upper motor neuron lesion or a lower motor neuron lesion when you ask the patient to protrude the tongue is, tongue deviates means there is a problem, but in case of lower motor neuron lesion, the paralyzed side will also show fasciculations, and fasciculations will be absent in case of the upper motor neuron lesion involved in these cases where the corticonuclear fibers are affected. And in case of Weber syndrome, even the substantia nigra may be involved, resulting in contralateral Parkinsonism rigidity. Now, second syndrome is the Claude syndrome. Here we have involvement of third cranial nerve with red nucleus and superior cerebellar peduncle. So patient presents with ipsilateral third cranial nerve palsy features, which we have already discussed, along with contralateral ataxia features because these are the crossed fibers of the superior cerebellar peduncle. Next, moving on to Benedict syndrome, otherwise known as lateral midbrain lesion. So here more of lateral part of the midbrain is involved, which includes red nucleus and superior cerebellar peduncle fibers, third cranial nerve, corticospinal tract fibers, and it also includes medial and spinal lemnisci, maybe also the trigeminal lemniscus. So the features include contralateral ataxia and intention tremors because of the involvement of red nucleus and superior cerebellar peduncles. Third cranial nerve involvement will result in ptosis, mydriasis, and diplopia, including loss of pupillary and accommodation reflexes. Corticospinal tract fiber involvement will result in contralateral hemiplegia, may show features of even corticonuclear fiber involvement. And because of the lemniscal involvement, there will be contralateral loss of discriminative touch, vibration, pain and temperature, both on the body as well as in the face region. Now coming to Perinaud's syndrome, otherwise known as dorsal midbrain lesion. This involves the superior colliculus level as well, that is the tectal region at the superior colliculus level, including the pretectal region. So what we have is limited upward gaze because of the involvement of vertical gaze center. So when you look at the patient's eyes in the resting position, the iris will be pointing downwards, resulting in the typical what we call a setting sun sign because of the down gaze at rest. And the patient will show pseudo Argyll-Robertson pupil, that is, Argyll-Robertson pupil has a feature of presence of convergence reflex but absence of pupillary light reflex. But in this case, although the convergence reflex will be present, the pupillary reflex will not be completely absent, but it will be mildly constricting pupil. So that's a pseudo Argyll-Robertson pupil. And patient will show Collier's sign. When he is asked to look up, the eyelids will be retracted. So that's a Collier's sign. So these are the features of Perinaud's syndrome, otherwise known as dorsal midbrain lesion. Then there is a syndrome called as Knoth-Nagel syndrome. Now this is affecting actually the superior cerebellar peduncles as they are descending from the midbrain on either side of the floor of the fourth ventricle. Well, it could be mainly because of a tumor or that is space occupying lesion, and this may involve forward, it may extend forward to involve even the third cranial nerve. So the patient presents with ipsilateral third cranial nerve features, palsy features, plus ipsilateral ataxia, because it's the same-sided superior cerebellar peduncle as well as the third cranial nerve. So whereas in other cases it was contralateral ataxia with ipsilateral third cranial nerve paralysis. So when you have same-sided ataxia and same-sided third cranial nerve involvement, that is what we call it as Neuroanatomy syndrome. During the brainstem lesion, especially if a patient is comatose, he may take up one of the two postures, or it's what we call as rigidity. They are the decerebrate rigidity and decorticate rigidity. There is a difference depending upon the level of lesion. Decerebrate rigidity is also known as extensor posturing, and this is because of the lesion below the level of red nucleus. So here, not only the corticospinal, corticonuclear and corticopontine fibers are involved, but also the rubrospinal tract fibers are also involved. So both corticospinal and rubrospinal fibers are facilitators for flexors. Now that being removed, the whole body goes into extended position. So we have extended arm, extended legs, plantar flexed feet, extended hip and knee region. Only the hands will be flexed a bit. So that is what is called as decerebrate rigidity. Now coming to decorticate rigidity, this is otherwise known as flexor posturing, and here the lesion is above the level of red nucleus. So corticospinal, corticonuclear and corticopontine fibers are involved, but rubrospinal tract is intact. So because of that, it will be sending fibers at least to the upper cervical level. So the arms will go into flexion. So there is a flexed elbow, wrist and fingers as you're seeing in the picture here, but hip, knee and ankle will be extended. So this is a decorticate rigidity. So based upon this postures or rigidity types, we can roughly gather as to where is the site of lesion. Throughout the brainstem lesions, whether it was in medulla or in pons or in midbrain, we get a combination of ocular features. So just let us list some of these interesting ocular presentations. We get a condition known as downbeat nystagmus. So here the eyes will be flickering upwards and coming down slowly. The typical vertical nystagmus wherein the eyeball goes up first and then comes down. So this is usually seen in case of Arnold-Chiari malformation, and this is because of the involvement of lower medulla, maybe the perihypoglossal nuclei, or it will be the involvement of inferior cerebellar peduncle region. Then we find features of Horner syndrome, which involves ptosis, meiosis, anhidrosis, anophthalmos and loss of cerebrospinal reflex. Now that is seen in case of lateral tegmental lesion, whether it is at the level of midbrain or pons or in the medulla. That's because of the involvement of descending autonomic fibers, which will be descending along with dorsal longitudinal fasciculus of Schutz. Then there is only eye blink response. This is seen in locked-in syndrome, which we discussed earlier with the pons. So here all corticospinal and corticonuclear fibers will be involved except for those fibers which will have relayed in the midbrain, and the upper face is spared. So patient can only communicate by means of blinking and vertical eye movements. So here the lesion will be at the level of basilar pons. Then there is internuclear ophthalmoplegia, wherein a patient is unable to look voluntarily to one side, especially now this is because of the involvement of medial longitudinal fasciculus. So again, the involvement can be anywhere along the brainstem, but most likely it will be between the pons and the midbrain region. So here the patient, if the right-sided medial longitudinal fasciculus is involved, the patient is unable to look to the right, but convergence otherwise is normal. It's only the left eye fails to adduct whenever the patient is asked to look voluntarily to the right side. So horizontal gaze to the side is affected, but convergence will be saved because medial longitudinal fasciculus is involved, but there is nothing wrong with the oculomotor nucleus itself. Then there is a condition where we have bilateral lateral gaze palsy, as seen in case of Mobius syndrome. So here both sided 6th and 7th cranial nerves will be involved. It's a congenital syndrome. So patient's eyes are adducted. He cannot abduct on either side, both eyes. Now coming to another condition called as ocular bobbing and dipping. Here, whenever the patient is just in the resting position, the eyeballs just drift downwards and suddenly they will get back to the normal resting position. So this drifting down rapidly and coming back slowly, that is the ocular bobbing. If the drifting down is slow and coming back is rapid, that is what we call as ocular dipping. So whether it is bobbing or dipping, the eyeballs are basically, it is going downwards and then getting back to their resting position. This is a feature of pontine lesions. Then we get a condition called as Argyll-Robertson pupils, where there is dissociation between convergence reflex and the light reflex. So in case of Argyll-Robertson pupils, the accommodation or the convergence reflex is present, but the pupillary reflex is absent. The pseudo Argyll-Robertson pupil, convergence reflex is present and pupillary reflex is only mildly present. So these are features of, whenever Argyll-Robertson pupil is a feature of involvement of pretectal nucleus, and pseudo Argyll-Robertson pupil features are seen in case of Perinaud's syndrome. We may have vertical gaze palsy, again a feature of Perinaud's syndrome. Now this is because of the involvement of vertical gaze center lesion, which is the rosal interstitial nucleus of medial longitudinal fasciculus. Then there is a condition called as seesaw nystagmus, wherein one eye will be abducting and extorting, other eye will be adducting and intorting, and then they will go on the other side. So the eye which was adducting and intorting will now go on to abduct and extort, and the opposite eye will go into adduction and intorsion. So this is a seesaw, like eyeball going from one side to other. Now this is found in conditions where there is any abnormality in the paracellular region, wherein it involves both vertical and torsional gaze centers, and we see a condition called as seesaw nystagmus. So some of these interesting ocular features, one has to observe it carefully, which will again be very useful to give us a clue as to what is the site of lesion. So thank you very much for the patient hearing. You can visit this site for other neuroanatomy videos. Thank you.